Okay, chapter 45, you really were only needing to go from 9:30 to 9:46 as you're going to be doing traumatic brain injury in Med-Surg 3. So that's how, that's the whole outline of this PowerPoint. And it's more involved than the majority of them that I do, just because we're going to talk about TIA, strokes, then the different types and stroke care, which is super important concepts for us to understand as nurses. So this one, I'm going to guide you slightly more than I do with the other ones, and you'll notice that with the PowerPoints as well. So a TIA is known as a transient ischemic attack. So this is also referred to, you'll hear talked about a mini stroke, okay? They often serve as a warning sign for an ischemic stroke that's going to happen. It's a brief interruption of blood flow. Symptoms typically resolve within 30 to 60 minutes of onset. So many people have a mini stroke and don't even realize that they've had one because it resolves. You know, when people start not feeling well, they'll give it time, you know. I mean, probably we're all guilty of that something's not quite right and we give it time and it resolves. So same thing happens with patients that have a TIA. They don't seek care because everything resolves for them. Diagnostically, we can see that they've had these events on MRIs later if they've had repeated events. But a single TIA is an indicator that the person's at a high stroke risk. And then recurrent or multiple TIAs can increase the risk for permanent brain damage, which hopefully makes sense. I'm interrupting the blood flow to the heart in one way or another. And yes, it does resolve. But if it happens over and over again, I'm at increased risk for brain damage. So key features of TIAs, these are actually right from chart 45.1 on page 931. So you can see everything's listed out for you. There's not a whole lot that I need to talk about. Remember, any of your words that you see that you don't know, you definitely want to look up. Now in here, throughout this whole PowerPoint, I've actually put everything in there for you. So like ataxia, aphasia, dysarthria, vertigo. I mean, I think you guys probably know that one, but if you didn't, I've put all the stuff in there for you. But if you come across words you don't understand, be sure that you look those up, okay? So stroke, also known as a brain attack, in your books talks about, it's one of the bullet points here, that a brain attack, the term is used to convey the urgency for acute stroke care similar to what would be provided for a myocardial infarction. Because truly, it's very, very similar to what's happening in a heart attack, only it's happening in the brain. So that's why they now use brain attack. So it's caused by any interruption of perfusion to any part of the brain. Should be treated immediately to prevent permanent disability. It's the third leading cause of death in the U.S. and a major cause of disability worldwide. And 137,000 Americans die each year from a stroke. So super important. Many centers now have stroke centers. You know, I know we've got at least one, if not two, here in the Flint area. But, you know, we have to have stroke centers in order to bring people in and move them through quickly because it is a very urgent matter if somebody's having a stroke. So, brain cannot store glucose or oxygen, is what that should say. So it must receive constant blood flow. So the brain itself doesn't hold on to glucose or oxygen. It's got to constantly be getting that from blood source, okay? So interruption of blood supply for more than a few minutes causes infarction, which is tissue death. So if I've got this constant blood flow that's needed so my brain can use oxygen and glucose and exchange out CO2 and all that, and hopefully you understand that process from patho. If I have an interruption of that, then my brain can't get what it needs. So I'm going to have some kind of death. And then so after somebody's had some type of interruption and some kind of brain death that happens or tissue death, brain edema can happen because there's been this injury. And so what's going to happen around it? It's going to swell. So the result of an infarction can cause increased cranial pressure, also known as ICP. And for you older people like me, that's not insane clown posse. Brain edema and ICP can cause secondary brain damage. So I have this swelling and this increased pressure, and so from a stroke, the patient can actually end up suffering a secondary brain damage, not necessarily from the infarction itself, but from the swelling afterwards. So big time monitoring happening in these areas where we're taking care of people that have had a stroke. So you have different types of strokes. So there's ischemic strokes and there's hemorrhagic strokes. But you'll also see under ischemic, there's thrombotic and embolic. That's because those are both some kind of clot. So ischemic, you have a thrombotic ischemic stroke or you have an embolic ischemic stroke. Ischemic is caused by some kind of blockage, either by a thrombus or an embolism. So thrombotic is caused by a thrombus, an actual blood clot. So the patient has, like, for whatever has happened, let's say it's a patient that has AFib and they're developing those clots, and we're going to go into that in detail when we go into the heart. But the patients develop these clots, and somehow it gets past the heart, because many times it ends up getting caught there and ends up going to the brain. So they've got this blood clot that's caused the patient to have the interruption in blood flow, or it's caused by an embolus, a dislodged clot. So that's like talking about the other day when we were talking about something breaking off the wall of the vessel. Remember, our diabetics are at higher risk for this because of that plaquey buildup that they're having. So as that's growing, they can throw an embolus in something that's broken off a clot. So then you also have hemorrhagic stroke, which is the second major classification of stroke. And so vessel integrity is interrupted and bleeding occurs in the brain space. So something's happened to those arterial vessels in the brain, and something caused a bleed. Okay, so that's the differences. So you have your embolic and you have your hemorrhagic. And then so I found this online. You can also look at table 45.1, page 932 for the differential features. And then this picture is from the internet, just showing the differences between thrombotic, embolic, and then there is the cerebral hemorrhage in the front. That it's showing you in the frontal lobe there, but the bleeding could be anywhere in the brain. So etiology and risk. So I listed your modifiable risk factors, your non-modifiable risk factors. So those are just listed right there for you. Under substance use, your book says particularly cocaine. So I put that in there as well, but these are things you can read through and you can talk yourself through and ask questions as to why these things would cause a stroke. Incidence and prevalence, listed this stuff out for you as well. That comes straight from your book. Important for us to know two things. Deaths from stroke have declined over the past 15 years because we have so much better treatment for it now. But the number of strokes happening to younger adults has increased. And that's going to go back to those modifiable risk factors. I mean, again, some non-modifiable. But the reason that our society is having this trouble is because of our lifestyle. You know, we don't exercise, we don't eat well, we have sedentary lifestyles, we smoke, we drink. I mean, all these things that we do that increase strokes. So younger people are now having strokes. But again, if I'm taking care of somebody who's a younger person that's had a stroke, it doesn't necessarily mean that they've been sitting around, not exercising, smoking and drinking, and doing all that stuff that is modifiable if they had a high, family history of the different things that could cause stroke, or a type 1 diabetic. So remember that we can't get judgmental about patients that have things like heart attacks and strokes because they could have prevented it. And remember again that no matter what, the patient's still going through it. They're a human being going through it, so we need to care for them. So nursing care for stroke patients, our assessment. Our assessment in the very beginning is going to include evaluating for fibrinolytic therapy, okay, or clot buster. So we're going to talk about that in a second in more detail. We need to determine if the patient has had any recent bleeding events or has been on an anticoagulant, because that would lead us to think that their stroke may be more hemorrhagic. We want to get a history as to when did this stroke begin, because there's going to be time issues going on here for the fibrinolytic therapy. And I need to know when this all started, and hopefully the patient or the family knows. I'm assessing level of consciousness and cognition. I'm asking the family to give me a comparison to what what the patient's normally like. I'm watching them walk. I'm seeing if they have any reading or writing things that have changed. And then I'm getting all the following that's listed right there for you. I don't need to reread that. And then symptoms of a stroke, the 5 most common symptoms of a stroke. Sudden confusion or trouble speaking or understanding, sudden numbness or weakness of the face, arm, or leg. And remember, we've already learned about Bell's palsy, which is not a stroke, but I may see that as well, so I've got to rule that out. Sudden trouble seeing in one or both eyes, sudden dizziness, trouble walking or loss of balance or coordination, and sudden severe headache with no known cause. So I grabbed this from the internet as well. Your book doesn't really talk about it, but it's really important that this is what we teach people outside, is the FAST. It's the acronym FAST, the face, arm, speech, and time. So is the face uneven? Is one side drooping? When they hold their arms out like a zombie walk, is one arm hanging down? Is the patient now slurring their speech? And time is of the most importance. I need to call and get them in right away. So this is good for us outside of the hospitals that we work in. So your book goes into good detail about the right versus left hemisphere and what's going to happen in the patient if they have a stroke in the right hemisphere versus the left hemisphere. So this is important for us to understand. So if there's right hemisphere involvement, that's going to involve the visual and spatial awareness. So proprioception is sense of body position, okay, like where the body is sitting. So your book actually talks, it does a good job, so make sure you read through this, of what the patient might experience if they have lost some of this proprioception. So a patient can be sitting, and if their right side is the side affected, it was talking in your book about the patient sitting in a wheelchair, and they could have a whole hand caught inside the wheelchair, the wheel of the wheelchair, and they would just think that they're sitting there with their arm propped up. So they lose this ability to know where their body is on the side that's affected. So the person having a stroke involving the right hemisphere, they will be unaware of the deficits most times, be disoriented to time and place, have personality changes such as impulse control, have poor judgment, so that goes along with impulse control, and the left side of the body may have weakness or paralysis. So if I have a stroke on the right side of the brain, it's going to be the left side of the body that's affected, and vice versa. A left hemisphere stroke is going to affect the right side of the body. So the left hemisphere for most people is the center for language, math skills, and analytical thinking. So the person having a stroke of the left hemisphere, and there you've got all your words that you need to know, have aphasia, inability to comprehend language, alexia or dyslexia, reading problems, agraphia, difficulty with writing, acalculia, difficulty with mathematical calculation, and then the right side of the body will have weakness or paralysis. And with agraphia and acalculia, either way, that's stuff that we talked about with also like Alzheimer's disease as well. So if you can start like drawing those dots to each other, that, well, obviously then the patient, if they start having that stuff in Alzheimer's, their left hemisphere has been affected, okay? So that's going to be a little bit different, but with a stroke, we know if we see this, it's likely a left hemisphere. So with stroke findings, your book outlines this as well. Possible problems with, actually, you know what? I'm going to pick back up here. I'm going to stop since I've only got like a minute and 20 seconds and I don't want to rush through it. So I'm going to stop right here and then pick up with the next one.